Fellow colleagues, welcome to today's student clinical meet. So we have two interesting cases. The first case will be presented by Dr. Lakshya and the second case will be presented by Dr. Sharath. I invite Dr. Lakshya to present the first case.
Good morning everyone. I shall be presenting a case of non-resolving pyelonephritis this morning. Starting with the patient details, he is a 46-year-old gentleman. He is married and a resident of Mohali and is a dairy owner by occupation. He presents to us with complaints of fever on and off for the past 3 months, dysuria for the past 2 months, and decreased urine output for the past 2 months. He had fever on and off for 3 months, up to 100 to 102 degrees Fahrenheit, 2 to 3 spikes per day. No prominent diurnal variation noted. Chills were present, but no rigor was noted. It would decrease on consuming antipyretics, associated with decrease in appetite, but no loss of weight was noted by the patient, and there is occasional history of vomiting. Dysuria was present in the form of increased frequency of urination and occasional burning sensation. The patient also complained of bilateral flank pain. There is no significant past history or no significant comorbidities for this patient. He consumed mixed diet. There is history of alcohol use for the past 3 years and history of tobacco chewing for the past 10 years. He had been treated outside for these complaints considering the long duration. In July 2022, he had been evaluated outside and the investigations were as follows. He had AKI with creatinine of 6.6. His urine examination at that time showed 20 pus cells and an NCCT scan showed a right bulky kidney with perinephric stranding present. He was treated along the lines of acute pyelonephritis and piperacillin tazobactam IV was given for 2 weeks. Hemodialysis was also initiated at this time because of advanced azotemia. However, despite this course of IV antibiotics, he did not show much improvement and he had to be started on maintenance hemodialysis until renal recovery was obtained. Subsequently, he switched hospitals and in the next hospital, his USG showed bilaterally enlarged kidneys, for which he underwent renal biopsy in view of non-resolution despite IV antibiotics. The renal biopsy was reported as inadequate and showed plenty of histiocytes with few eosinophils. Subsequently, it got reported as a case of acute interstitial nephritis, probably because of the presence of eosinophils, and the patient received 3 doses of methylprednisolone pulse dose followed by oral steroids. However, he showed no improvement despite this modified regimen and his symptoms worsened in the form of flank pain and decrease in urine output. He was labeled as a case of chronic kidney disease at this point and started in maintenance hemodialysis once per week. It is at this point that the patient comes to PGIMER for a second opinion on 26th of August. On admission, his physical examination reveals blood pressure of 130/90. Peripheral pulses all were palpable and regular, 76 per minute. Respiratory rate of 14 per minute. He was maintaining saturation on room air. Pallor was present, but no peripheral lymphadenopathy could be noted. His per-abdominal examination appeared unremarkable. Respiratory system examination showed only bilateral normovesicular breath sounds. Cardiovascular system examination revealed S1, S2 normal and no murmurs could be appreciated. He was conscious oriented to time, place and person. His higher mental functions assessed were all intact and his cranial nerves showed no deficits. These are the baseline investigations that were obtained on admission and a few investigations which are from outside hospitals prior to his admission. So as we can see, noteworthy is the fall in hemoglobin which is happening over time. Apart from that, at his initial presentation, before he was treated as a case of pyelonephritis, we noticed that he had an elevated TLC, which subsequently has normalized. However, his renal function tests show persistent abnormality and rather a deterioration is seen in the form of creatinine levels and azotemia is also worsening. There is no transaminitis noted. His inflammatory markers are elevated. CRP is 230. and subsequently also it stays elevated. LDH is elevated, and this is the urine RME report which was obtained from outside. Further investigations showed a urine culture single-time positivity to Klebsiella pneumoniae. This was sensitive to piptaz. However, the patient had already received IV piptaz in outside hospitals, and subsequently he also received IV piptaz on initial admission in PGIMER. USG whole abdomen showed bilateral bulky kidneys with thickening of the urothelial lining, and this is the report of the renal biopsy which had been done outside. Interstitial infiltrates with mononuclear cells which were labeled as histiocytes. Focal tubular destruction with few granular casts were also seen. However, no cellular cast could be seen. And it was finally reported as inadequate because little renal parenchymal tissue could be obtained in the biopsy. So at this point, what are the differential diagnoses that were considered for this patient? And what were the possibilities in view of most of the investigations suggesting a diagnosis of acute pyelonephritis? But the pyelonephritis is not showing any improvement despite extensive course of IV antibiotics. So the differentials considered in a case of pyelonephritis which is not improving despite IV antibiotics is either there are unaddressed anatomical abnormalities which are causing recurrent bouts, or there is an unaddressed renal or perirenal abscess which needs drainage but has not been done, or there is a non-bacterial etiology such as urogenital TB or fungal infection which would not respond to IV antibiotics. Malignancy is a far off differential in this scenario, and these three conditions which are rare however are seen especially in the setting of a gram-negative infection of the kidney, xanthogranulomatous pyelonephritis, renal parenchymal malakoplakia, and an exceedingly rare entity known as megalocytic interstitial nephritis. All three of these diseases are associated with chronic inflammation of the kidney and ineffective phagocytosis of the bacteria. With these differentials, the patient was admitted on 26th of August. Subsequently, his urine for AFB came out to be positive on 29th of August, and it was reported as 10 to 99 AFB per 100 high power field. Patient was subsequently about to be started on ATT for his illness, considering a diagnosis of urogenital TB. At which point his CECT abdomen was also obtained, and it showed bilaterally bulky kidneys, but there is no evidence of any focal lesion anywhere. Also, there is no evidence of any collecting system involvement. This is the sagittal image of the same CT, showing bilateral bulky kidneys with homogeneous enhancement. No focal lesion is visible. Now, the odd thing about this CECT was that although the microbiological test is showing positivity for AFB, it is very rare for urogenital TB, especially renal TB, to not involve the collecting system. And isolated parenchymal involvement with renal TB is a rare entity. We also had another clue here. We had bilateral enlarged kidneys. So if we consider the differentials of enlarged kidneys at this point, then we can divide them into smooth enlargement or a cystic or nodular enlargement of the kidneys. Smooth enlargement is primarily seen in conditions such as diabetic nephropathy, acute pyelonephritis, lymphomatous involvement of the kidney. However, for our patient, although pyelonephritis is the first differential, diabetes is not, because there are no records of elevated blood sugar readings. And since there is no cyst, no mass, and no nodularity in the kidney, all the differentials for enlargement by cysts or masses are probably not applicable for our patient. So we further refined our diagnosis on the basis of the available imaging findings. With the absence of a discrete mass or urological abnormality, recurrent pyelonephritis, an abscess, xanthogranulomatous pyelonephritis, malakoplakia, RCC, all of them become very, very unlikely. and CECT was considered not to be suggestive of tuberculosis. Subsequently, 7 more urine AFB samples and urine gene expert for TB was also sent. However, all of them returned to be negative, at which point a possibility of infiltrative disease was also considered, and he underwent renal biopsy. Before going into the renal biopsy findings, at this point we had 4 prominent differential diagnoses to be considered. The first was fungal pyelonephritis, for which we had host risk factors in the form of steroid use, which he had been given outside. However, what was against this diagnosis was that the disease is bilateral, which is usually a feature of fungemia. But there is no evidence of any other source of hematogenous seeding for this patient. And isolated urogenital involvement of the fungus will usually be unilateral. Also, it would not explain the initial course of the illness prior to receipt of steroids, while he was treated with IV antibiotics but still did not improve. And there is no microbiological evidence for this. For tuberculosis, bilateral involvement would be explained, and also we have a urine AFB positivity. However, tuberculosis usually has collecting system involvement. Isolated parenchymal involvement would be unusual. Malignant infiltration could be considered, especially considering the diffuse enlargement of bilateral kidneys, which would be consistent with a hematological malignancy. But there is no marked anomaly on the peripheral smear. There is no peripheral lymphadenopathy which could be appreciated. No retroperitoneal nodes could be seen on the imaging. And it should have been detected on the prior renal biopsy which was conducted. These 2 differentials are very, very rare. And the most important point against them is that there is absence of a PAS positivity. Both of these entities show PAS positivity on biopsy. So this is the final biopsy report that was done in PGIMER. These are the images at a low power. There is little of the renal architecture that can be seen. At the center we can see a glomerulus, and there are a few of the renal tubules that we can see. And the rest of it shows an extensive interstitial infiltrate. If we go to the high power for this is the glomerulus and this is the tubule, and the rest of the interstitium is infiltrated by certain atypical cells which are showing a large nucleus and which are showing clear cytoplasm. So these atypical cells had to be further characterized on IHC. This is the CD20 IHC marker which has been applied. As you can see, there is strong positivity for these interstitial infiltrating cells for CD20, at which point they were labeled as B lymphoid cells. CD3 shows a few cells, highlights a few cells, probably the reactive T cells which are involved in this process. And MUM1 also shows positivity for these interstitial infiltrating cells. So this biopsy finally got reported as renal biopsy showing infiltration by a diffuse large B-cell lymphoma, non-germinal center phenotype. What could we have thought in retrospect that would have allowed us to suspect this diagnosis or consider this diagnosis earlier? So in retrospect, we had bulky kidneys on ultrasound and on imaging, which were indicative of a hematolymphoid malignancy, infiltration by hematolymphoid malignancy. Secondly, although we had a single culture positivity in the urine, despite IV antibiotics, the sterile pyuria in this patient was persistent. That there were no further positive cultures after IV antibiotics, but there were pus cells present throughout. And the biggest clue is the first renal biopsy, which had been reported as inadequate, actually had shown exactly this, that there was no renal tissue involved, and entirely there were atypical cells seen in that biopsy. So likely that was not inadequate, renal tissue was obtained, but the renal architecture was replaced by lymphomatous cells. Having obtained a diagnosis of lymphoma on the renal biopsy, he further underwent bone marrow biopsy, which showed hypercellular marrow with sheets of atypical lymphoid cells, which were replacing the normal marrow. Flow cytometry at this point was suggestive of abnormal B lymphocytes, which was consistent with what we saw on the renal biopsy. Patient was started on chemotherapy, and the final diagnosis made by the unit was chronic kidney disease, secondary to infiltration by a diffuse large B-cell lymphoma, non-Hodgkin lymphoma, DLBCL, non-germinal center, stage 4 in view of involvement of two extranodal sites, the kidney and the marrow, along with anemia, and he received 1 cycle of rituximab and reduced dose of CHOP regimen while in ward. On follow-up, currently the patient is off hemodialysis and urine output is adequate. After 2 weeks of his discharge from the ward, his serum creatinine was 3. Currently, on the latest follow-up, he has received 3 cycles of chemotherapy. Initially, both of them were reduced R-CHOP, reduced dose R-CHOP, R-mini-CHOP. And the last cycle that he has received has been R-CHOP, which he has received on 31st of October. He's planned for a PET-CT after 6 cycles of chemotherapy and is currently under regular follow-up. In this patient, we will discuss the primary and secondary renal lymphomas, what is the spectrum of renal involvement in a lymphoma, what clues can be obtained from sterile pyuria, and what are the possibilities and what are the causes where we may consider a false positive AFP. Primary renal lymphoma is defined as isolated renal involvement. There should be no evidence of extrarenal lymphomatous involvement in the visceral organs or lymph nodes at first admission. There should be no evidence of myelosuppression. And renal lymphoma obviously has to be detected on histopathological examination. The issue is that it is an extremely rare entity. Less than 1% of all extranodal lymphomas are actually primary renal lymphomas. More often than not, it is a secondary renal lymphoma. That is that the primary site is elsewhere and there is renal involvement in the case of lymphoma, which is the scenario in our case. It is much more common than a primary renal lymphoma. It is infiltration of the lymphomatous cells into the kidneys, and usually it involves bilateral involvement and also includes the adrenal glands. This is actually quite common. And if we see the autopsy case series for non-Hodgkin lymphomas, then 30 to 50% of patients will show microscopic evidence of infiltration of the kidney by a lymphoma in a case of lymphoma. However, antemortem detection is much lesser. Imaging is only able to detect 10 to 15% of these patients. What are the mechanisms of renal injury in lymphomatous infiltration? So the first hypothesis which is posted for this is that there is parenchymal infiltration by the sheer bulk and mass of the cells which are infiltrating into the kidneys. This causes hemodynamic changes by putting pressure on the vasculature and tubular dysfunction. Then there is an entity known as minimal change nephrotic syndrome, more common in Hodgkin lymphomas rather than non-Hodgkin lymphomas, whereby T cells are activated by a permeable factor which is released by the lymphocytes, the atypical lymphoid cells that is. Another mechanism is glomerulonephritis, and the last mechanism, which is extremely rare, is acute tubular necrosis. This is all excluding the other mechanisms which are present in hematolymphoid malignancies for causing renal injuries, like cases of dehydration, sepsis, and paraprotein involvement, paraprotein causing damage to the tubular cells. This is simply for the renal injury in a lymphomatous infiltration of the kidneys. Our patient had demonstrated the finding of sterile pyuria. After the initial first culture positivity, all his subsequent cultures were sterile, but his pyuria was persistent. So pyuria, as obvious, is the persistent finding of white cells in urine in the absence of bacteria, as determined by aerobic bacterial techniques. About 14% of women and 2.6% of men are affected. It is related to infectious as well as non-infectious etiologies, which is relevant in our case because the case is not related to infection, maybe due to presence or recurrent use of a urinary catheter, recent procedures or renal stone disease, foreign bodies in the urinary tract, or even a urinary tract neoplasm. although the classical teaching is that sterile pyuria is suggestive of a genitourinary TB. These are the sensitivity and specificity data for Gene Expert and AFB smear as compared to the gold standard, which is the MJIT culture for mycobacteria. So Gene Expert has a much higher sensitivity, obviously, up to the tune of 94%, and sensitivity of AFB smear is much lesser. So in our case, after the initial AFB smear positivity, the Gene Expert for urine was repeated twice, and also PCR of the biopsy tissue was also conducted, but all three of these reports were negative. What to think for a case of false positive AFP? Like, what may be the causes which had led us to have a report of a false positive AFB in this case? That would be other mycobacteria other than Mycobacterium tuberculosis. Prominent among them is that the smegma bacillus, M. smegmatis, is one of the mycobacteria and may be AFB positive, especially relevant for male patients. Other bacteria such as Actinomyces nocardia may be responsible. Oocysts of Cryptosporidium, Isospora and Cyclospora are also acid-fast. Tinea saginata X, and this also relevant for male patients, that the sperm head may show AFB positivity. Apart from that, a breakdown in the laboratory techniques for processing AFB smears may be responsible, a reuse of positive slides, even tap water contamination, and improper discoloration with sulfuric acid while staining may be responsible for false positive AFBs. This is a case which had been reported from PGI, perinephric stranding and bulky psoas, mimicking pyelonephritis in a case of non-Hodgkin lymphoma of kidney. This is the CT scan image, which is showing an enlarged right kidney with thickening and enhancement of the pelvic LACL system, hydronephrosis, and grossly distorted renal architecture. And these are the biopsy images of the same kidney. This is another case which was reported from PGIMER, bilateral massive nephromegaly, which was the presenting manifestation of a mixed phenotype acute leukemia. So the take-home message that we drew from this case was, infiltrative disorders must always be kept in mind in case of a non-resolving pyelonephritis with nephromegaly. Secondary involvement of kidneys is, of course, much more common than primary involvement by a renal lymphoma. And sensitivity of Gene Expert is more than an AFB smear, and in certain cases, AFB smear may be false positive. Thank you.